So now what I would like to do is to introduce Sayward Montague, whom I believe most of you probably already know, who will be the moderator for this panel. Sayward's career has taken her from the public sector labour movement to employee benefits consulting and into the non-profit sector advocacy work. In 2011, Sayward joined the National Association of Federal Retirees advocacy team working on pension and retirement security issues. She took over the role of Director of Advocacy in early 2016, and Sayward will be introducing our panelists to us. Over to you, Sayward.
Thank you, Simon. Welcome everyone to this panel on a continuum of care from the Canadian seniors' perspective. We're privileged to have some noted experts in the healthcare field with us today from several disciplines. Before I introduce them, though, I'd like to share an interesting piece of information about them. They all come from these different backgrounds, but they all belong to the same exclusive club. And I think some of our volunteers and certainly one staff member belong to the same club. It's the 2012 Queen Elizabeth Golden Jubilee Medals that they were awarded by the Governor General. So it tells us a lot about our panelists and certainly our volunteers and staff and their involvement in their communities. So with us today, we have Dr. Jeff Blackmer at the end with the Canadian Medical Association. He's currently serving as their Vice President of Medical Professionalism. His expertise has led the association on issues such as end-of-life care and physician-assisted dying, medical professionalism, and assisted reproductive technologies. We have Nadine Henningsen, the Executive Director of the Canadian Home Care Association. Nadine's involved in many national initiatives and advisory boards that address a wide range of public policy priorities like primary health care, patient safety, integrated palliative care, innovation and info technology, and health human resources. And we have Teresa Dellar, Executive Director and co-founder of the West Island Palliative Care Residence. Teresa is a member of the McGill University Palliative Care Council, is on the executive of the board of the Alliance des Maisons de Soins Palliatifs du Québec, and the Healthcare Business Women's Association. She's also active with the English Community Health and Social Services Network, the West Island Chamber of Commerce, the Canadian Hospice Palliative Care Association, and the International Hospice Association. So welcome all. You can read more about our panelists in the biographical information included in our AMM binder and on the app. So I'll just set the context a little bit for our conversation. We know that longevity and our demographic landscape have been creating new challenges for Canada's healthcare system for some time, and that's going to continue for the foreseeable future, especially for Canada's seniors. In 1970, life expectancies for men and women were 69 and 76 years respectively, and in 2012, the World Health Organization estimated that our life expectancies are now 80 for males and 84 for females. So we're living longer and generally healthier lives. But it's certainly a different context. In 2015, we had an historic first in Canada. We had a higher proportion of elderly Canadians than we did younger Canadians. Moving on to the care end of things, we know that with home care, some organizations have estimated the savings could be in the billions of dollars to the healthcare system. We know there are gaps in long-term care across the country. In New Brunswick and Newfoundland, for example, seniors face liquidation of assets to access public long-term care. Nationally, the number of long-term care beds per 1,000 seniors has stagnated and wait times have jumped quite a bit. Hospital bed shortages are another concern. And there's been, of course, a transformative discussion in Canadian healthcare over the last couple of years, one that may impact us all at some point or another, and one that we all have an opinion on, I'm sure. It's physician-assisted dying and how that integrates, or even whether that integrates with good palliative care. Healthcare doesn't happen in silos or with clean transitions from stage to stage, especially for seniors and their families. Let's say the jump from an acute health concern or emergency and then back home, or the progression of a disease or illness, and navigating from stage to stage is nearly a full-time job in itself. Seamless, organized continuum of care is important to seniors and their families to address their needs, to take care of them well, assure their comfort in healing and the outcomes, and then we can't forget the savings that are associated with it as well, and the pressures that can be eased off the system. So we know there is and will be an increased need for these types of care, and with that, we'll get started with some questions and hope to dig into some solutions, maybe. If time permits, we will ask for audience questions, but I will be a strict keeper of time, I'm sorry to say, but not sorry to say. So first, I thought we'd begin with Nadine, and Dr. Blackmer and Teresa, please feel free to join in. It's really a conversation that we'd like to have with you today. We know there are issues with access, so the number of spots available at a certain facility or perhaps the wait times that people experience. Are Canadian seniors right now accessing or able to access the right kind of care at the right time?
Thanks, Sayward. I'd like to just start by thanking you so much for the opportunity to be able to share our home care experiences with you and have this dialogue this afternoon. There are actually some really great examples of really good access to home care services across the country, and I want to share 3 of them, and they're actually coast to middle to coast, and they're all tied together with one concept. And it's interesting, the philosophy of this is that home, not hospital or long-term care or residential care, is the best place to recover from an illness or an injury, to manage long-term health conditions, and to die with dignity surrounded by loved ones. So that whole concept of let's see what we can do to enable someone to live independently and safely at home. So the 3 examples that I'd just like to share with you is one out in BC, and it's called Home is Best. And their whole philosophy about home is best is that they wrap around care to the individual. So it's very intensive home care, but they also access community supports and primary care to ensure that all the health and social needs of that individual are met. And what was interesting out in BC, what they're finding is that by meeting all those needs and empowering the patient and the individual and involving their family caregivers, more often than not, the individual after a couple weeks says, thank you very much, I really don't need home care anymore, I'm set, I'm good to go, and off goes home care. Now, the same project has been reproduced in Ontario, and it's called Home First. So once again, they built from BC, and they're now looking at Ontario with Home First. And out in Nova Scotia, it's called Home Again. So we're really quite excited about seeing this whole philosophy change or culture change, and really helping the access to home care services for certainly seniors, frail elderly, but individuals that really need it.
Add, Dr. Blackmer or Teresa?
Just very quickly, I think one of the commonalities, and we've looked at those models as well, and I'd also like to echo our thanks for the invitation today. This is, as you know, a very key group in terms of our engagement, particularly on issues around seniors care and senior strategy. And I feel very at home here with my gray hair. So one of the commonalities in those systems is a political commitment. And so, for example, and Saskatchewan is another example where we've seen a real political commitment to what we're starting to call integrated care. So it looks at all sort of levels of care, whether that's home or residential or acute or chronic care health facilities, and finding what's best for the patient. So really the idea of a very patient-centered philosophy and building the care around the patient and what they need at that point in time. And those systems also share other commonalities in terms of involving patients and patient advocates in those discussions, as well as healthcare providers, and also a very robust support framework in terms of information technology and allowing providers across those different sort of levels of intervention to share data and not make the patient repeat the same story again and again and again. So there are absolutely silos where that's being done very well that we need to look at, you know, how can we scale those things up in other jurisdictions as well.
Nothing more to add. Most of my focus is on palliative care and palliative care at home and in hospice, and certainly although it's improving across Canada, we have a long way to go, and one of the best examples is probably out in Vancouver, where they have a really good home care service, as well as in Toronto. Quebec, unfortunately, where I'm from, is lacking very much in that area, but we are nowhere near where the UK is and some of the other countries, so we really have to do some catch up. We have to run a little bit faster.
So you've mentioned that you're seeing this in different communities, certainly provincially, and then in some municipalities they're doing some work on this. Political will is certainly required, but with the political will comes the price tag question. So how do some of these factors get integrated? How do we start to build them together, and how do we pay for it?
And you know, I find that certainly we've found, looking at different models across the country, is the models particularly, as my colleagues have mentioned, in Saskatchewan and in BC, if it's an integrated management system like a regional health authority, the funds tend to be able to move from a hospital to long-term care to home care. So fundamentally, they almost follow the patient, which is the ultimate goal of where we want to go. So when they can actually flow those funds to the right place at the right time with the right provider, then they actually, more often than not, find cost savings. So really, if we can break down those funding silos, it's a win-win-win to the provider, the system, and the Canadians.
I mean, I really think that the money is there in the system, and this seems to be the general consensus. It's not that we need to pour more money into the healthcare system. We've been saying this for years. It's that we need to use it more wisely. And so while I may not agree with all of sort of the initiatives in Ontario, at least the guiding principle of reinvesting in areas that make sense demographically around home care and long-term care, and trying to shift sort of where those resources are invested makes a lot of sense, because certainly the pot of money is big enough to accomplish what we're trying to accomplish. It's just, for years it hasn't been used properly because it's such a political issue. So you've got a 4 to 5 year political cycle where politicians are trying to point to easy wins without looking at the longer term impact of those funding decisions.
And I think that there's a lot of Band-Aid solutions being put out there, and I agree with Jeff. The money is there. That's the good news. The more difficult part of it is trying to get people to use it wisely. The money is there. We just have to figure out how to encourage our politicians to use it wisely, and to make sure that it's directed right at the patient and their families, and not rather at the institutions.
And if I may just add one more comment to Jeff's comments is I think also that you have to be careful of what you measure. Because if you set a goal and you're going to measure something that's going to get you to a point that you really don't want to get to, and I'll give you an example, is often hospitals measure admission rates or whether their beds are full. So we want to empty our beds, so let's discharge them to home. And that may or may not be the best thing for the individual. So you always have to be really careful. There's political will, but we have to be careful about what we as a country want to measure in our health system.
So it's sort of reframing the success indicators and putting that into context too.
Sure.
Since we're talking about money, maybe we could talk about the first federal budget of the new Liberal government. They outlined their intent to put some resources behind a stimulus plan on infrastructure spending. And they included reference to long-term care facilities over the next couple of years and $3 billion promised for home care. From your perspective, where does that leave us or lead us? Is it enough? Is it a first step? How does this fit in the bigger picture and in the bigger health dollar picture?
Can I start by saying it's good news and bad news?
Yeah, I was gonna say.
The good news is that the commitment to have $3 billion towards home care is great, because home care is being recognized. It's a priority. We are having very substantive discussions, certainly at the Canadian Home Care Association, with governments from right across the country where we wouldn't have before. So that's the good news. The bad news is that home care is underfunded and under-resourced. And I'll give you quite an astounding fact is that only 4% of our public dollars go towards home care. So even though over the last 15 years governments have said we want to take care closer to home, we want to meet the needs of Canadians closer to home, only 4% of all the money we spend in the public system goes towards home care. And that has actually stayed the same for the last 15 years. So that's the bad news. So we're hoping that these substantive discussions will I guess, certainly be supported by the resources and the funding that's required.
So the 4% figure stayed the same for the last quite some time. Have systems or organizations been able to do more or less? Has it, with that same kind of figure? What would you like to see that figure be?
You know, it's disappointing, because what home care organizations have had to do, and I'm sure many of you have experienced this firsthand, is they've had to ration, they've had to delist services, they've had to make do with less. So it really has, because the demand has been increasing exponentially, but the funding and the resources haven't followed. So often what the default is unfortunately an individual will end up in a hospital and have to stay in the hospital until they end up moving to a long-term care facility, which they never should have had to do. So that's a challenge. Where would we like to see it? I think that we'd like to see it, certainly it's going to be in incremental steps. That's a challenging question. Could it be a 7% solution? I'm not sure, but we definitely know that 4% is not going to take us to where we want to go.
On the budget issue, I mean, I agree. It's, the devil is in the details here, and so we've seen the numbers that have been committed, and we're certainly waiting to see exactly what that looks like in terms of how that'll be distributed. I think the infrastructure question is a really important one, because what we're seeing is obviously a demographic bump, and the statistics are very clear on this. We're going to have the baby boomer generation go through, require very different services than the generation after them, and so we don't want to make a mistake of for example, building, a ton of long-term care homes for this generation, and then have this infrastructure after that that's not going to be needed, and try and decide what to turn that into. So investing some of that in home care just makes so much more sense in terms of helping people age where they are for a whole variety of reasons, but certainly the infrastructure one being one of them, so that we don't go out and build all these long-term care homes and then try and sort of shovel people so that they fit the solution that we've come up with, when there are better ways to use that money from a number of different perspectives.
I think the infrastructure is very, very important. When back in the 50s, we built so many schools for all the baby boomer children, and we're going along the same lines of building a lot of senior residences, and that's not the answer. 4% sounds terrible to you. We wish we had 4% in palliative care home care. We do not have 4%. It's probably about 1% in palliative care at home, mostly because our patients require 24/7, and there's just almost no resources for that. So they have a long way to go.
Are you seeing increasing demand for palliative care and hospice care?
Absolutely. And as what we're seeing too is not only, and we're one of a few homes in Quebec that provide palliative care for any illness. So it's not, you don't have to have cancer or ALS, any kind of end of life disease and prognosis comes to our residents. And we have 23 beds, so we're the largest in Canada. And again, we do not have enough beds. And not everybody wants to come to a hospice, and we don't want everybody to come to our hospice. We want people to go where they want to go. And if they want to die at home, we want them to die at home. There's just no resources. And it's very taxing on the families. And there's also no resources for the families. So people are sent home and with a palliative profile. So for 28 days, they're in Quebec, they're allowed to get a bit of extended home care. So they're allowed to get probably about 8-9 hours a day, which of course doesn't cover it. And that's only for 28 days. So if you're still alive after 28 days, then you have to go back into the hospital, go through emergency, and people that know the system well know what to do. All you have to do is go through the door, go into the emergency, you'll get another 28 days. And I don't know if that's a Band-Aid solution. That's a pretty good example of one.
Seems like a really bad setup.
Yeah, it's a bad setup, and it's only going to get worse. I'm very lucky in that I was listening to your average age, and my dad just turned 90 and my mom 88. So, if we look at all of those people, there's more and more people that are living longer and living well and wanting to stay where they want to, where they've been living. And if they want to live at home and if they want to die at home, they should. But there's no structure for that. And building a lot more hospices is also not the answer. As much as I run a hospice, I run Canada's largest hospice, the answer is not necessarily in hospice. It's partially, but it's also in home care.
So just digging into the home care aspect of things a little bit, I imagine the caregiver aspect features pretty significantly in the home care, right through the whole continuum from when you're first accessing care going straight through. So have we resourced enough in Canada for the caregivers, for the people that are with the individual going through, whether they're a senior or have an illness? Have we thought about them? Is there a trend where people are starting to think about them and resourcing for caregivers as well, including them in the structure of things, I guess?
Can I answer that first? We just did an environmental scan, again, about palliative care across Canada. And one of the things that was a common thread across Canada, which was very interesting, and I'd love to take a poll if I could in here, but obviously we don't have time, is the caregivers across Canada, you know, are very happy and very appreciative of the huggy-duggy support that they get and the loving support. But what they're really asking for is, how do I turn my loved one in the middle of the night? How do I change a bed when a bed needs to be changed? They're asking for concrete support, concrete resources. They're asking for, I heard you talking about toolkits. They're asking for toolkits. How do I help care for somebody at home? And I think that's where we haven't developed a really good framework for palliative care at home, and we have to do that.
You know, I think things are trending in the right direction, though.
I
mean, I do feel like we've got, you know, if I look at 10 years ago, the attention that was paid to caregiver stress and burnout, for example, or even formal federal programs, which are not sufficient, but are, again, trending in the right direction. The time is now to start doing some of these initiatives, because there is attention being paid on the burden and on this sort of unofficial part of our healthcare system that relies not only when patients are at home, frankly, but a lot of people in this room will know when they're in the hospital, we rely on informal caregivers to provide a lot of that care because nursing and medical staff is stretched so thin. So really, people are starting to very clearly recognize this, I think, and we have seen a little bit more of a commitment of funding. You know, again, it's not enough, but I think we're headed in the right direction, and hopefully we'll see more improvements over the next, you know, short little while.
I say this generation changed the way we came into the world with birthing rooms, and this generation can change the way we leave. And they can advocate and be strong voices for the rights at the end of life and the rights when you're ill and in an elderly situation where you need care. So we need to be the voices for people that can't speak, and this is a perfect place to begin.
And I would just add maybe a frame. I have the opportunity to be the president of Carers Canada, which is a national organization of caregivers and caregiver support groups. And we went out to caregivers, and although caregivers come in all shapes and sizes, we actually talked to many, many of them. And what was interesting is they all had common needs. And very much like my colleagues have just mentioned, is the first one is we have to safeguard their health and well-being, because caregivers shouldn't and can't get sick because they care. Now, the challenges there is most of those programs are run through the provincial or local programs, and it's called respite services. So as you know, sometimes they're there, sometimes they're not. Another challenge that caregivers face across the country is financial burden. Often there's a lot of unexpected costs of caregiving and providing care for your loved one. Is it parking at hospitals, or is it buying equipment for your home to keep your loved one at home? So they shouldn't suffer financial difficulties because they care. And Jeff mentioned that there are some programs, particularly from the federal government, but also in Nova Scotia and Manitoba, that are actually giving caregiver allowances that are working very well. We talked about caregivers' need for access to information, and you always know when they need information, it's at midnight. It's never 9 to 5, you know that. So how do we ensure that caregivers get access to the information they need? And the last thing, and this was an interesting one that caregivers identified they needed, is they need employers that understand their commitments. And for a young carer, they need educational environments that understand their commitment. Because if you've ever been a caregiver, which if you haven't been, you will be a caregiver, is it happens, you have to sometimes take off an hour to take someone to a hospital or a doctor's appointment. Sometimes things happen and you just have to stay away from work for 1 or 2 days. So it's not predictable, and what we need is we need employers that recognize that and respect the role of caregivers. So those are kind of the 4 planks that we're certainly moving forward to champion caregivers' needs.
Thank you. So changing gears a little bit, on the continuum of care, we've talked about all aspects, but I'd like to get a little bit deeper on one thing, and that's the physician-assisted dying. We know in Ottawa yesterday, the Senate sending an amended bill back to the House of Commons. The Justice Minister has said the government will not accept the amended bill, so who knows how that's going to go over the next couple of days. But some people have said that there shouldn't be a need for physician-assisted death or those provisions if we only had really solid palliative care. So I'd like to ask Dr. Blackmer and Teresa and Nadine if you have any thoughts as well. But what are your thoughts on that? Are the two things mutually exclusive? Do they integrate, and how do we make sure they integrate?
So, yeah, this has been obviously a fascinating discussion at a national level, and the silver lining to all this is that it's really made us talk about death and dying in a very open, forthright way. And I often say, because this is a big part of my work at the current point in time, it's not lost on me the irony that I spend 99% of my time talking about an intervention that actually only 1% to 3% of Canadians will use, and not nearly enough of my time talking about something like palliative care, which almost every Canadian could benefit from. And if we look at, depending on how you frame it, only 20 to 30% of Canadians have good access to high quality palliative care. If I stood up here today and told you 30% of Canadians have access to renal dialysis, there'd be riots in the street. And yet here we are complacently accepting the current reality. It's completely unacceptable. So once we figure out this assisted dying piece, we want to spend a lot more time focusing and talking about high quality palliative care, about proper funding, about access, about a national strategy, about training for medical and other healthcare professionals. This is so critical. It's vastly more critical to the whole issue of quality care at the end of life than assisted dying. And so while we feel strongly we need to get this right, we've certainly made our views clear in terms of our preferences for a national approach to assisted dying. We are following the debate today very carefully. We still maintain that the attention, the focus really does need to shift back to that conversation around access to palliative care.
Well said. I think, again, just to echo Jeff's comments, we very strongly feel that it's given us a forum to speak, so that's been wonderful. If I talked to somebody about palliative care 5 years ago, they would have walked away. Being in Quebec, our law was passed last December 10th at midnight, and December 11th, people started applying for it. And most of the assisted suicides have happened in Quebec City, actually, and in the outer lying areas. We have had our experience with one ourselves that sadly is happening today. So I had a real struggle coming here today because my staff needs a lot of support. And again, we don't provide that service in the residence, so if a person decides on that, they have to be transferred out. Simply because it's not our specialty. Just because we deal with people that are dying doesn't mean that we deal with assisted suicide well, and we don't. We deal with natural death process, and palliative care is a natural death process. So it's given us a forum to talk. Again, as Jeff said, when people ask what I support, I always say that when the scale is even and 100% of Canadians have access to palliative care, and 100% of Canadians already will have access to assisted suicide, then you can decide. Right now you can't, because at least 70% of Canadians have no access to palliative care. So how can you choose? Right now, you can't. The scale is not even. So we have to even that scale. We have to make sure that a framework of palliative care is on a national level. We have to build it on a national level. We have to educate. We have to educate people in long-term care facilities on how to provide excellence in palliative care. Just because people say that they do palliative care doesn't mean they do it well. And we want to make sure that there's a framework, that there's an accreditation program. And we're out to help the government do that because it's there. We just need to give people the tools to do that.
And can I ask, it was really quite interesting. I had an opportunity to listen to the presentation prior to this panel about the advocacy work you're doing. So all of you that are involved in your advocacy work, write these 3 words down, okay? Because we're going to challenge you to think about how you're going to build this into your toolkits, is palliative care first, and everything that goes with that.
Yeah. If you have palliative care, then you can make the decisions afterwards.
Right. So wrapping up then and looking forward, because we've got about just a few moments to go, and then maybe we could have some brief questions from the audience, because I see everyone looking very rapt and into this conversation. The federal health minister will be meeting with the provinces to negotiate a new health accord, possibly over the coming months. So there's been some buzz about that. What would you each like to see included in a new health accord that would improve or help build a continuum of care for seniors? I know we've heard a lot about some of the frameworks and the national standards that should be put in place, but sort of from maybe your top 3 to top 5, what should be in there and how should it all play together?
So we don't have, well, we kind of have a top 5 or a top 3, but you know, one of the keys for advocacy, particularly in today's environment, is really narrowing in, right, and being very clear in your messaging. And our messaging is very clear around a senior strategy, particularly in relation to innovation. So I can tell you, having spoken to a number of folks in Health Canada and in the Minister's office, the buzzword for the Health Accord is innovation. So if you want to, just like we had 3 words earlier for palliative care, you want to focus in on the healthcare accord, it's #innovation. And particularly as that relates to strategies for seniors care, and we've talked about a number of those. And so we'll be looking to really promote that, to have a national strategy, a properly funded national strategy that provides integration across all levels of the healthcare system. I know they will be looking at other issues like mental health, like national pharmacare. You know, there's a number of things sort of in the minister's mandate letter, and those are all very important, but we will certainly be focusing in on our senior strategy and our demand-to-plan strategy.
A framework for palliative care, consistency across Canada, access, so that everybody can have palliative care and end-of-life care. So access would be my word.
We're actually, and it's funny because you'd think that I would be able to give you 5 things right off the cuff, and I can probably give you 50 things, to be quite honest. But we're trying to be, as Jeff said, you have to be concrete and quantifiable, as you guys know. So we're actually building our plan right now, and it's called Better Home Care, a National Action Plan. And we're working with the Canadian Nurses Association and the College of Family Physicians. And we're going out and we're talking to stakeholders, and we're framing our conversations in 3 really interesting ways. As an individual Canadian, I want to live safely and independently at home. I want to be able to return safely from home, back home after a visit to the hospital. And when the time comes, I want to be able to choose to die with dignity in my home. So given those 3 frames, what can the federal government do with the provinces, particularly around home care? So we're actually getting ideas and thoughts right now around that. So I'm going to give you one more piece of homework before they cut off my mic. If you could write this down on your papers, is thehomecareplan.ca. It's a website right now, and it's active, and it's thehomecareplan.ca. And on it, we're asking for ideas. There's a very brief survey, and we're looking for ideas from you. We're looking for suggestions on what we should put in this home care plan, and we just love to ignite every one of your experiences and your expertise to be able to reflect it in the plan.
Just before we go to the mics, just very briefly, I just want to pick up on that because this is something that drives me crazy in this whole debate around assisted dying. You mentioned dying with dignity at home, and of course we've seen that term co-opted now for the assisted dying movement.
Yes.
And opening this up to anyone with any condition as if somehow that's dignified. And it really, I think, does a tremendous disservice to palliative care. And to the fact that somehow every death in Canada that's taken place historically right up until now has been undignified. In fact, the most dignified deaths are the ones that take place at home, surrounded by loved ones in an environment of that person's choosing. And we need to take that language back. I'm so distressed by how this has been co-opted and now is used interchangeably with assisted dying for anybody at any point in time. So dying with dignity is not what some people would want you to believe that it is.
And it's very confusing for the public because they think that they,
There is no other
exactly,
way to
that they're
be
both,
dignified.
right.
exactly.
Yeah, I can attest to that, having
Yeah.
family, yeah. So we'll open it to the mics just for a few moments, and again, I will be a strict timekeeper. I'm sorry, but not sorry. So we could go to mic number 1 first.
Kathy Lyne, Regina Area Branch. Sorry, that's up in the ceiling. I just want to know what is being done, or if anything is being done, to try and incorporate home care into the Canada Health Act. I know it's been discussed. I just wonder what your comments or thoughts are on that. Thank you.
It's one of my 50 wish lists, Kathy. But realistically, what we believe that we can move forward and ask for is a separate piece of legislation, and I think we'll take baby steps on that one. And interestingly enough, coming out of these Better Home Care Plan consultations is the first step that says we need national principles for home care, we need standards, and we need some sort of measurements that we can measure, and we can be transparent on all home care programs across the country. So baby steps, but that's our ultimate vision.
Mic number 3, I think, was up next.
Durham Cody from Central Newfoundland. We got a real problem in Newfoundland. One of the problems is our deficit. The government haven't got a pot to piss in. They got a $9 billion deficit, and so they've just reduced the home care a person can get from 5 hours a week maximum to 2 hours per week maximum, and in some cases 1 hour a week maximum. And I agree with everything that's been said here today, and I thank you for all your help in promoting this issue. The other problem is when you transfer money to the provinces, how do you ensure it goes into the healthcare? Because you transfer money to Newfoundland, it'll go into everything but healthcare. Okay, so that's an issue. If the money is being transferred from the federal government, there should be some provision where it got to be spent in the healthcare system and not go elsewhere. Okay, that's my comments on that.
Again, I think to what, good point, to what Jeff said is there's money there. It's just, and it probably is transferred, I mean, I can't be certain, obviously, into healthcare. It's how it's used that's important, and probably used to build infrastructures and create that, and maybe that's not where it should be used. So again, it could be transferred there, it's how it's being used.
And I agree with your comment also about building home cares. If they only could see the concept of putting all these millions and millions of dollars, if they just built new home care in St. John's, it cost over 40 million to build it, or 50 million, and as a result it's filled up. But if they only could take that much money and put into home care, it would make an awful difference.
Absolutely.
For sure. And I think that will be a key part of the health accord, will be how those transfers are used. So what we've seen over the past few years is as the health accord has run out, the previous one, Paul Martin's health accord, and then the Conservatives tied it to, you know, inflation indexes and that type of thing, we haven't seen any sort of accountability on the provincial end for how those dollars are spent. This is an opportunity, once again, to tie that very much into things like outcomes, right? So you need to be able to show outcomes to continue to get these transfers, and so we will have more clarity that it is being spent on healthcare.
That's something we've seen in the environmental scans and things that we do is, you know, tying it to outcomes and to measurables that are more appropriate with what we actually need to see.
Exactly.
One last question from Mike 4.
How does the program, like in Alberta, it's called self-managed home care, fit into this whole thing? I know, and when there are that type of thing available, why isn't it more put out to the public? And I'll just give a quick experience. We accessed that for my mother, and but we could have had it we only had it for a year. We could have had it for 4 years if I'd have known about it. I'd talked to home care about all the home care services. It was never mentioned until I asked if it was such a thing available. Then I was told, yes, it is. So a couple of things. Why aren't they telling people about these things? And how does that fit in? Like, you couldn't pay a family member, but you could manage your own health home care. And so happened we had a live-in caregiver who we paid her then with that money to take care of my, you know. So how does that fit in? Is it a program that's available in other places, or is this just in Alberta?
I have good news for you, is that it's actually available in most provinces, and interestingly enough, it started with the young disabled population, because they said, even though I'm in a wheelchair, I want the capacity to be able to manage my own care. So it actually came through a social services type funding, but the home care ministries across the province are actually looking at it very seriously, and we have a Saskatchewan contingency, because I think I saw them over here. Saskatchewan has a very robust self-managed care program. Alberta has one. They're obviously not trying to promote it too much, so I'll talk to my colleagues over in Alberta and ask them what the heck's going on there. But there's definitely these self-managed care programs, and interestingly enough, in this action plan, it's coming through over and over and over again. So don't be surprised if you don't see that clearly in the action plan, that we have to have faith and we have to have belief in our individuals and in patients who are getting home care, and we have to give them the opportunity to be able to be independent and manage that money.
It allowed my mother to die at home
Right.
with with the caregiver that she's had one-on-one for a long time, and with family, and to die with very dignified care in her own environment because of this self-managed home care. And you know, because through the home care regular system, your home caregiver isn't always there, and it's not always the same person. And so it really needs to be visible. Because they even tried to discourage me from taking it.
Yeah.
I did get it.
You bring up a good point, is often we have to go out and seek resources. They may be there, but often they're not widely publicized, they're not marketed like other things. And so in the midst of caring for somebody or in the midst of being sick, we often have to go out and be the investigator as well. So whether it's home care, palliative care, and that's very difficult, and it's difficult for the caregivers, and that's why we continue to need everybody to be a voice for those people that can't be. So thank you for that.
That's right. So wherever the person approaches
Right.
the healthcare system to get the help I need,
Right.
all those options need to be put
Right.
forward.
Right, and now you can be an ambassador for that program.
Bet I am.
So we have advocates and ambassadors, and we all have some homework now, thanks to our three panelists. I'm sure we can all agree this was, first of all, a bit of a lightning round of a panel. There are so many different aspects we can explore. We didn't touch on age-friendly communities and how that plays into the whole continuum for seniors, but we can all agree there are areas of tremendous opportunity and need for change, especially with the focus on the health accord now coming and other elements. So it'll be fascinating to get together in the future sometime, I hope we can, to see how we've moved the needle and how things have shifted. I'd like to thank each of our panelists for the time here today. Teresa, particularly you with your team behind dealing with something so difficult and significant as professionals.
Thank you, and thank you all for participating.
Nadine? Yes. Thank you.
Thanks very much. Thank you. Thank you.
Is this a membership? No.
I need a pen.
Well, let me see. Do you receive, or are you eligible to receive, a public service judges, Canadian Forces, or RCMP pension? Maybe it's not a membership, but it is a token of our appreciation. We really would like to thank you all very much for this panel. Thank you, Sayward, for moderating. We really do appreciate that. You've all given us some excellent perspectives on healthcare, particularly pertaining to the continuum for seniors, home care, long-term care, palliative care, and maybe a little bit beyond, and the points in between. On behalf of the National Association, thank you very much for your time here this morning.